Welcome today to the NHCC Educational Committee Roundtable Forum on Cannabis 101, where we bring medical professionals together to demystify the health and wellness power of cannabis to help break down the Latinx community's long-held cultural taboos and beliefs on cannabis. My name is David Sanchez, board member of the National Hispanic Cannabis Council and Cresco Labs VP of Product Development. Today, we are here with two other NHCC Board of Directors, Dr. Phil Burns and Dr. Craig Ontel from the New York State of Mind. Thank you guys for joining us today.
Thank you for having us today, David.
Thank you.
Of course. And I'm your host, David Sanchez, but I wanted to introduce our two guests today. Dr. Craig trained at the NYU's Rusk Institute of Rehabilitation. From there, he spent nearly 15 years of private practice in NYC. He also served as the director of Ambulatory Orthopedic Rehabilitation Hospital at NYU Langone. In May of 2021, he actually left NYU to become the CEO of State of Mind Cannabis. And for our other speaker, Dr. Phil Burns, Doctor of Osteopathic Medicine, has been practicing for over 20 years. He actually completed specialty training in the field of physical medicine and rehabilitation at NYU Langone's Health Rusk Institute of Rehabilitation Medicine. Upon completion of that training, he founded and has operated a successful medical practice based on a patient-first principle. He specializes in orthopedic rehabilitation and prosthetics, and he's also participated in academic rounds on the neurological rehabilitation service for many years as the assistant clinical professor at NYU's Langone's Health. Dr. Burns is driven by his desire to make a meaningful impact on the state's opioid crisis. So welcome, folks.
Thank you. Thank you for the introduction.
Of course, of course. I see you guys spend a lot of time at NYU. Makes sense why you guys crossed paths. How did you guys cross paths?
You know, Dr. Burns or Phil and myself met literally day one in medical school. And we went through medical school together. We went through residency together. And we've been in and out of practice together for over 20 years now. So our collaboration in the medical field spans about 30 years.
Wow, that's amazing. Glad that you guys connected and all for the better. Today's NHCC's Educational Committee Roundtable on Cannabis 101 for our intent today is really to have an informative overview on how cannabis works with PTSD. And so before diving into our topic for today, I did want to say a few words about the National Hispanic Cannabis Council's mission, which is to educate the U.S. Hispanic community on the health, wellness, and the economic aspects of cannabis to empower their support and participation in the industry. It's also our mission to help demystify the plant through educational programs such as this one, to promote the health and power of cannabis and to break down those long-held cultural taboos and beliefs on cannabis. So with that being said, guys, let's jump in. Guys, what is PTSD?
I'll take this. So PTSD is a mental condition that's triggered by a shocking, scary, or even a dangerous event. Fear produces sort of the fight or flight response that everyone knows to protect you or avoid harm. So everyone goes through a range of emotions following trauma, but most people recover from this in a reasonable amount of time. Some people, however, get kind of stuck, and these symptoms can last longer, get worse, or interfere with their daily lives. That's PTSD, all right? It usually begins about the first 3 months following trauma, and usually has to last at least 1 month to make the diagnosis and severely interfere with your your daily life and your functioning. The diagnosis is usually made by psychiatrists or psychologists, and they typically use a 17-point questionnaire, self-reporting questionnaire called the Davidson scale, and that primarily will go and look at sort of memories of the event that reoccur, nightmares, flashbacks, different triggers that exacerbate these or bring these emotions and memories back. avoidance, fear of avoiding thinking about the event or places that remind you of it. And then other things such as being easily startled, being always on guard, have trouble sleeping, difficulty with memory, irritability, interfering with relationships, etc. Feeling detached, negative thoughts.
Oh,
You
interesting.
appreciate where I'm going. Yeah.
Yeah, no, thank you, Dr. Burns. And what are some of your experiences with the Latino population as it relates to PTSD?
So Dr. Burns, thank you for that background on PTSD and the diagnostic criteria. I just wanted to touch on one more thing, and that's the prevalence. And the prevalence of PTSD in the general population is 3.6% per year.
Wow.
So this is a lot more common than folks typically think. In the Latin population, the number is even higher. And there are a multitude of factors that have been identified. There's social factors, there's family factors, and there's economic factors that come into play when we speak about the Latin population or the Latino population in PTSD.
That's interesting. Those numbers are surprising and interesting to hear its prevalence. What are the current solutions for PTSD?
So PTSD right now is managed in a multitude of ways. There's non-pharmacological ways such as biofeedback, hypnosis, psychotherapy, and then there's a lot of pharmacological treatments for it. And primarily antidepressants is what people have been using. More recently, we've started to get into cannabis or look deeper into cannabis for the treatment of PTSD. And we've had mixed results. However, the most recent study, which is the only federally funded study, has positive results. What happens with PTSD is PTSD affects the brain. And the part of the brain it affects is the amygdala. And the amygdala is responsible for that fight and flight response that Dr. Burns just mentioned before in his talk. And what we noted is when we study the amygdala and we image it and we expose someone to a traumatic event that should cause a response, if they're using a cannabis product, which I'll get into in a minute, that response is muted in the brain. Thus, they're experiencing less of that trauma, or they're encoding less of that trauma. This all goes back to a word that I love to use when we're on these talks, and the word is homeostasis.
Yeah.
And that's where the endocannabinoid system comes into play. And PTSD, like a lot of other conditions which we've spoken about, is usually secondary to a dysregulation of this homeostasis. And cannabis, particularly cannabidiol, addresses this.
Interesting. So you mentioned some of those current solutions. What is the efficacy of some of those solutions? And do we see the same cultural taboos with hypnosis, with you mentioned non-medication type of ailments? What's your experience there?
So the experience has been great. The difficulty that we have is, as practitioners, is data. It really is, and reliable data to base how we prescribe cannabis. In the study I just mentioned, it was out of the VA system, and there were 150 participants with documented PTSD. They were broken into two groups, and this study had a lot of words that us doctors like: randomized, blind, double controlled. It makes us smile because it checked all those boxes that would give a study validity. However, 150 people was a very small sample set. The results of the study, though, were fascinating. 2/3 of the people, well, back up a drop, 75% of the people were placed on a combination THC CBD product, And the other 75 people were placed in a placebo, meaning they didn't get any medicine, a sugar pill, open close quotes. When all the results were tabulated, 2/3 of the patients in the cannabis and CBD protocol no longer met the diagnostic criteria to be diagnosed with PTSD, which was very impressive and then some.
That's outstanding.
Now, it's outstanding. Where the study fell short was the total amount of people in the study. And these folks benefited greatly from a percentage of THC of about 8 or 9%, which is a low percent, and an equal amount of CBD. So they were on a 1-to-1 ratio. Our goal is to have the least amount of THC to get the desired effect. So as larger studies come out, they will be studied with lower concentrations of THC compared to CBD. However, the results of this study were encouraging, to say the least.
That's amazing. Those results and that data is very important to what we'd like to see for people really trying to dive into this. And I wanted to focus on a particular aspect of this study. And you mentioned a low dose concentration, equal parts THC, CBD. I think this is one of those taboos that the Latinx community really struggles with, and trying to understand not everything leads to intoxication. Can you help speak to that a little bit? What is the difference between intoxication and something like a therapeutic dose?
Thank you. And I was smiling when you said it, because it's one of those common things I see in the office all the time. And we want to use a cannabis product for someone in lieu of opioids or an antidepressant or a sleeping pill, which often has side effect profile the patient does not like. However, the cultural or social impression of cannabis in the Latin community, especially in the folks who are my demographic and older, is, hey, this is just for people to get high on the street. So we need to break that cultural barrier down, and it really comes to education. And by taking the limited amount of time it takes and educating the patient that the other benefit of the CBD is it negates the cognitive effect of the THC. So we can look them in the eye and comfortably tell them that we can start them at a very low THC concentration and a higher CBD, and it will not affect them cognitively at all. And once we break through that barrier, it's a lot easier working with the patient and their family moving forward. We always want the least amount of medicine, and no matter what we're talking about here, to get the desired result. And that's what the difference is between a therapeutic dose versus too much medicine for someone with a, I don't want to use the word overdose, but just where they take too much.
Side effects.
Side effects.
Yeah. Well, speaking to those side effects, from that study that you referenced, did we see any side effects from the cannabis medication?
We did, and you're always going to have a small segment of the population who doesn't respond well to anything. That's the wrong way to phrase that. So you'll always have a segment in a study population that gets an adverse response. So what we saw in this, in some folks, it made their anxiety worse. It made their PTSD worse. But that number was very small in comparison to the amount of patients that got benefit from the cannabis study.
Interesting. So to dive a little bit deeper into that, you mentioned that at the end of the study, 2/3 no longer qualified for PTSD. Specifically, how did the cannabis help, and what caused them to not qualify anymore?
That's a great question of how cannabis helped the patient not qualify for PTSD. PTSD is a clinical diagnosis, and Dr. Burns mentioned some of the clinical criteria before, and I'll ask him to do it again when I'm done with the scientific background as to how this works. So what happens here with PTSD, as I mentioned before, we have a dysregulation or an abnormality in the homeostasis and particularly the balance of neurotransmitters. And we're talking about certain parts of the brain. We're talking about the amygdala, which is responsible for fear conditioning. We're talking about the prefrontal cortex, which deals with emotion. We're talking about the hippocampus, which deals with memory consolidation. And then we see something called a dysregulation of the hypothalamic pituitary axis. So to summarize it, our homeostasis is off. The amygdala with the fear conditioning is part of the criteria, the fear response for PTSD. The prefrontal cortex with emotional regulation, also part of the criteria for PTSD. And the hippocampus with memory consolidation, also part of the criteria for PTSD. So what happens here is cannabidiol, which is the active ingredient in cannabis, increases serotonin and dopamine. Those are the two substances that we measure in the brain that are decreased in depression, in PTSD specifically. And with regards to serotonin, that's what the antidepressant pills that we prescribe try to raise that level. So what happens with the cannabidiol is we increase the serotonin and the dopamine, thus decreasing the level of stress, which leads to better patient coping and less remission rates. So it's the cannabidiol that affects the serotonin in the brain, which helps with the symptoms of the PTSD.
That's amazing. And just so we're looking at both sides of the coin here, what were some of the negative effects or side effects that we saw? I think often people think I'm gonna gain weight if I take any type of cannabis medication. What did we see from the study, and what have we seen in year two's experience?
Yeah, what the study showed really was, with the exception of a few patients who felt worse and not better, which we'll see with any study, which I mentioned, it was usually more of your softer side effects: dry mouth, red eyes, maybe some increased appetite. But these are all things that we can mitigate and work with in a very benign manner. There was nothing in the study that came up that would have halted it or precluded it.
That's interesting. And I think that's something that that is interesting that you also mentioned, is the similarities of depression, right? Can you speak to what are the similarities and how do they differ? How is PTSD same from depression? And are they ranked in the same way? Are they measured in the same way through that Davidson scale?
It's not that they're measured in the same way through the Davidson scale, but they kind of walk together hand in hand. And in depression, for example, there is an avoidance of things, avoidance of traumatic events, there's avoidance of maybe fear. Same thing with PTSD. There's less social interaction. Same thing with PTSD. There's less work. Same thing with PTSD. And they both show a decreased serotonin level in the studies that have been performed. So they're closely related, and it's very hard to find or label someone with depression and not PTSD. They are interrelated. Two different diagnoses, don't get me wrong. You could have depression without having PTSD, but if you have PTSD, you typically have a component of depression as well.
How does one come to find out that they have PTSD? Is this something that somebody comes into your office and says, hey, I think I'm qualifying for this? Is this something that their family member brings them into the office, or how does PTSD get discovered in someone?
Phil, do you want to do this one or should I take it?
So obviously, usually there's a traumatic event that triggers this, and patients have a myriad of symptomatology that we've discussed, problems adjusting, sleeplessness, irritability, flashbacks, nightmares, etc. And they typically would see their primary care physician first, who would typically quarterback this. They'd be referred typically to a psychiatrist or psychologist who can get more in depth with the diagnosis, the Davidson scale, etc. And they could also sort of quarterback the treatment plan, whether it's addition of psychotherapy to make sense of their fears and concerns, and also develop certain coping skills to handle what they're going through. That, in conjunction with a cannabis provider who can take them through different strains and percentages of THC, CBD to get what works best for them. I will note one thing that Craig was talking about in terms of studies that are being done. Typically, it's a cannabis product or a placebo, and to have sort of consistency and control in the study, they're not adjusted within their cannabis product during the study. So the efficacy may be something that anecdotally we would see a higher result than potentially through a study, but more studies need to be done with different ratios, different terpene profiles, etc., to really determine which strain and profile provides the best response for the individual.
Interesting. And I think that we often, when we think about PTSD, we immediately think veterans or someone who's been to war. And I think some of the studies were used with actual veterans. How do we see the US and the US veterans? Do we see support for this type of research? And what are some of the challenges ahead?
So you are 1,000% correct, David, in that a lot of the studies have been with veterans. And one of the larger studies was done over a few decades, and it was post-Vietnam War veterans. And the study showed that roughly a third of them suffered from PTSD. So that was one of the things that moved that VA study, which I mentioned before. The VA study was the first federally funded study out there. So the veterans themselves are excluded from cannabis. The physicians in the VA system are federal employees. They are not writing cannabis prescriptions because it's not legal at the federal level. It's legal at the state level. And unfortunately, a lot of veterans are tied into the VA system for all of their health care and do not have the option to step out. So as long as this remains a Schedule I drug, and as long as these VA physicians are not able to prescribe it, a lot of the veterans are left without help. Your prior question I've been thinking about here for a little bit. And one of the real important factors that I see in the Latino community when they come in and they have depression or something with PTSD is sometimes they're a little more difficult to treat because of the access to healthcare is more limited in that community. And that's something I'm saying that's not shocking to anyone who's watching this video right now. But very frequently, people coming out of that community have not had the same access to healthcare, or it took longer to get the access to healthcare. So sometimes when they're seeing the problems are magnified. Also, there's a lot of interfamily relationship. And a lot of stuff is kept inside the family. And it's tried to be worked out within the family. So by the time that it shows up in the office, it's usually gotten a lot further along the road. And that's one of those cultural issues or conditions that we're very cognizant to in healthcare.
That's yeah, it's unfortunate that not everyone has access to such, you know, therapies. But what can you say to a veteran who perhaps is not in a state where cannabis is legal? What are their options?
So their best resource right now is actually reaching out to the VFW, the Veteran of Foreign Wars. The VFW as an organization is very pro-cannabis for veterans for treatment of PTSD. And they would be an excellent resource for either cannabis providers in the state or either out of the state. That is the first thing that I would recommend, is reaching out to their local VFW.
Interesting. And is there any studies or any kind of research that is done prior to, say, veterans going to war, or like a pre-medication, if you will?
Unfortunately, no. It's difficult to predict who would suffer from PTSD. So it's very hard to, it's not like you're doing a physical exam and you see someone has flat feet and maybe they can't run in war. We don't have that. This is a subjective diagnosis, meaning we can't touch it, taste it, smell it, or feel it. And it's reported back from the individual. So the PTSD, when we make the diagnosis, it's usually a questionnaire that the patient is given and they self-report the answers back. So even in a screening tool, if they did screen everyone, they would likely miss a lot of it because they haven't had those traumatic events yet in their life where they would be responding, yes, this has happened.
Interesting. Such a complex thing to work on. How else do you think cannabis helps with PTSD?
Cannabis overall helps. And I'm going to say it again, homeostasis. I keep going back to it time and time and time again, and I will as long as we do these talks. So cannabis resets that endocannabinoid system and helps with homeostasis. And I'll give you an analogy. When your stomach is grumbling because you're hungry, that's the endocannabinoid system telling you you're hungry. So as this research moves forward and as we get a lot more granular, not only with ratios, but with specificity of the breakdown products of the CBD and all those components, we will be much better at managing PTSD from a cannabis perspective. That's
amazing. And, I think that I'd like to start wrapping up with some future and forward-looking thoughts. What kind of research can we expect in the future? I guess one question is, like, from this study, we learned so much. How could we improve upon this study? You mentioned that, there's a lot of words that doctors like to see to prove efficacy, to prove validity. What kind of things would you change in the future to this kind of study? And what kind of changes can we expect to the Davidson scale? Is this something that is outdated? Is this kind of screening antiquated? What do we see there forward-looking?
With regards to the study, I mentioned it before, it's really all about sample size. That's always, you got to build a house from the foundation up, and you need the right size sample pool to make any of the data meaningful. So that prior study I mentioned was 150 people, 1,500 people would be much better.
Wow. That's
the size of study you need, because that study will allow you to vary the ratios of the THC to the CBD. You'll get a large enough sample pool to get some meaningful data out of it. So the first thing is you got to increase the sample pool. Second thing I would do is add some more variability to the product. And being in the cannabis industry, much like you, we understand there's lots of different types of cannabis out there.
Yep.
And depending upon the type of cannabis you use is the result you're going to get, open, close quotes. So branching that out as well. As I keep going and you run these numbers, by the time I'm done, I could use 1 million people in the study. And I got that. But the more folks we have and the more product availability will allow us to hone this in and do our future studies a lot more focused and concentrated.
And for the second piece of that question, Dr. Burns, do we think the Davidson scale is outdated? Do we think that this is something that we need to improve upon? Or is this just the best that we have for now?
I think it's the best that we have for now. You know, it does a fairly good job of identifying patients, but also tracking symptom reduction and efficacy of treatments. You know,
And if you were to talk to someone who thinks that they have PTSD, what would you tell them to? What would you recommend for them to do?
I think seeking help really is the simplest and most obvious answer. Usually with you know, their primary care physician, you know, trusted person that they have relied on in the past. Obviously, for other health-related issues, I think would be a good person to start with and can direct them through receiving the appropriate help. And usually the help is sort of a more holistic, multidisciplinary approach would obviously give you the greater chance at treatment success. And that would be, again, psychotherapy, could be support group, or individual therapy, use of a cannabis product, possibly you know, an SSRI, a medication, pharmacologic, but then also, you know, involving the patient with their family members and their community. You know, there's a few distinctions within the Hispanic community that is a help and a hindrance. One is the fact that you know, obviously the concern of being labeled or with a mental illness, to being perceived as being you know, not weak or not strong, and also concerns about you know, fear of discussing personal items to an outside person or stranger, or someone outside the family. But at the same time, there are several things within the Hispanic community that lend themselves well towards someone being successful in their treatment. Very strong sense of family, very strong sense of community, etc. So the support group is there. Patients just need to be able to, again, have the realization that mental illness is common in the United States, and it's not something that will stigmatize them going forward. Suppressing or internalizing things are only going to make things worse, and getting ahead of it will lead to resolution and you know, restoration of quality of life, getting them back engaged in their relationships in society.
I couldn't agree more. Thank you both. I think it's so important to bring these topics to the table, at the family, you know, dinner table. I think it's our obligation to help people find the help that they need if they need it. And I think talking about it, educating folks, letting them know that, one, they're not alone, two, there's viable therapies, ways of navigating these types of traumas. And it's important to know that cannabis is an avenue and a potential solution. Dr. Craig, did you have any closing thoughts?
Yeah, I do, David. Thank you. And, you know, and thank you, Dr. Burns. That was an excellent synopsis there, and it made me think about what I was going to say now. You know, we spoke about healthcare access before, or lack thereof, in the Latino community. And I just want to drive that point home for a minute, because I've seen it firsthand. And I've seen the end result of lack of healthcare firsthand in the Latino community. Medicine is an art, not a science. And I always want the patients and anyone who's watching this to never forget that. And the most important person is the patient, not the doctor, not myself, not Dr. Burns. And if someone is watching this now and they know they have something going on, or they know they have PTSD, they know they have depression, and they show up to see someone like me or Dr. Burns and they don't get the answer that they think they should get, look again. Do not settle for that, okay? It is very easy to not treat this and it will get worse. Always listen to yourself with that. This is a healthcare access issue for a lot of folks. So don't let someone tell you you do or don't have something if you don't believe that. And remember, nobody knows their body better than the patient themselves. So if you don't get the right answer the first time, look again and again until you do. I just wanted to drive that point home, because we see that all too often, where someone will come in years later and they will relate a story that they mentioned this to a healthcare provider years earlier and it was kind of brushed off.
Those are great words and great suggestions for the folks hearing. It's very powerful to hear that from you.
On a side note, without the recording, so David, one of the saddest things I ever saw in healthcare, which is why I'm saying this, I'll never forget this. About 5 or 6 years ago, I had a Spanish-speaking elderly lady come into the office, and she didn't speak any English at all. And she looked and smelled like cancer. I've been doing this long enough. And the nurse came in to help me translate. As good as I am with Spanish, I'm not that good. And this was the story. I'll never forget it. Never. It got me to my core. Single elderly Hispanic lady who doesn't speak English would show up at the clinic, and single Hispanic elderly lady is not getting respect in healthcare if she's not there with a male. I'm saying this. They ignored her pain. By the time I saw her, I ordered the right test. She had metastatic breast cancer and she was done. And it happened because she was an elderly, and she wasn't even that old, 60s, Hispanic speaking single lady. And I'll never forget, one of the other Hispanic doctors from Brazil, Hispanic, told me that only happened because she's a single elderly Spanish speaking lady. And if she showed up with a man, she would have got proper health care. I'll never forget that. I know that's not appropriate for this talk, but when I sit here and I say, don't take no for an answer, that's why. And I've seen it.
I appreciate you sharing that story. I think, maybe it's a little strong, but I mean, this is what we're trying to combat, and this is why we're here, and I really appreciate you saying that, and I mean, I couldn't agree more. No one's going to know their body better than themselves, and such a sad story to hear, but it's us, repeating these stories and making sure that doesn't happen again. Okay, well, that concludes our conversation today. Thank you so much to Dr. Craig and Dr. Burns for joining us today. Your guys' voice is so important to this conversation.
Thank you for having us again, David. And, I hope what we, went over today, Dr. Burns and myself, gives a meaningful impact. And, PTSD is complicated. Depression's complicated. Like Dr. Burns and I said before, this is subjective, meaning you can't touch it, taste it, smell it, feel it. So it's hard for physicians to completely get it, and it's hard for family members, and it's not like you twisted your knee or your ankle. It's a work in progress. We're making significant gains. We're beginning to, at least with cannabis. And Dr. Burns and myself speak about this frequently, and we couldn't be more optimistic for what the future holds.
Yeah. And thank you guys once again for joining us on today's conversation, where we help demystify some of these topics that are at the front of everyone's mind. Thank you to the National Hispanic Cannabis Council for bringing this forum together. We'll see you next time.